But you need to stop and walk. If you're in the airplane, you need to get up and walk in the aisle as soon as you can. You need to be constantly moving those legs. I had a friend whose father traveled from Oklahoma to LA for a conference, which is about a 3-hour flight. Then a couple of days later, made the 3-hour flight back, climbed up in the pecan tree, and died from a clot. A clot is called a thrombus. A moving clot is called an embolus. So where did that clot that broke out of his legs, where did it go? Into the lungs, and clotted off his lungs, where he died in the tree, which was a whole other issue. So if you have bedridden patients and they're conscious, you need to be sure to tell them they need to be moving their legs all the time. If they are unconscious, you need to be moving their legs for them. Or you get those mechanical compression things, which are pushing blood back to the heart. My husband used to fly all the time, and I was saying, be sure you're moving your legs. All right, most of the blood stays in the venous system, unless we need it for sympathetic, need it for exercise. All right, cardiac output. What's the cardiac output made up of? Check to see if she'd already answered. Should have asked, did you already put your clicker? No, I'm not sure if she did or not, so I'm going to go ahead and stop it. Okay, good job. Of course it's up there, but still. All right, now let's look at one of the case studies on the lab report. You have somebody who's in atrial fibrillation. If they're in atrial fibrillation, if you've listened to the online lecture component about arrhythmias, heart disease, you know that this means we don't have that atrial systole. If we don't have the atrial systole, that contributes to decreasing stroke volume. Atrial systole contributes 10% of the cardiac output at exercise, 35% of it, 10% at rest, 35% exercise. So someone in AFib, first of all, they're not going to have as much cardiac output. They're going to be tired, winded easier, not going to be able to go as far and fast. And then what's the second problem with AFib? Blood pools, pooling blood clots. And that will either go to the lungs if it's in the right atrium, or it'll go to the brain if it's in the left atrium and cause a stroke. So either a pulmonary embolism or a stroke will be the result. That's why you've got to get that AFib treated or be on anticoagulants. All right, what determines stroke volume? Mark all that apply. So it's A through D. So now you see why I wrote all that on the board, even though you had it in your slides. That way I get to keep it on the board and I get to put arrows on it to talk about what happens next. 13% of you got that right. Degree of contractility, end diastolic volume, total peripheral resistance. What is that blood pressure? The resistance in the peripheral system that's going to have to be pumped against. So what determines end diastolic volume? Of course, some of these are test questions, which I gather you knew that because you keep taking pictures of them. Some of them were pulled right off the test with paper scrambled is all. The trial and error method is the most powerful way of learning. So that's one of the reasons why the clickers have increased grades since I've started doing those. Because you get it wrong, and then I tell you what the right answer is, and then you write that down, and then the next time you see that on the test, for example, then you do it right, because now you've learned.
Should convince Dr. Collins to do that.
Well, she does her think times. We just talked about clicker questions yesterday when she said she calls on individual students because that makes everybody talk. And I said, well, that's what the clickers are for too. Makes everybody think.
I don't know, there's something about the clickers that I like. Because, you know, she'd be sitting there lecturing and we're kind of wondering, okay, let's do a think time. And we were like, oh.
You don't know if your answers are right on think times.
Yeah.
Oh, you don't?
No.
She doesn't tell you. She just
You go
puts
through
them
the
out
whole
of
class and then just turn them in.
Mm-hmm.
Oh.
Yep.
Well, I don't want to miss out on the powerful trial and error method of learning.
I guess her trial
I wanna
and error
do
is whenever she calls on students.
Teachable moments.
Yeah.
I'm always looking for the teachable moments. Oh, there we go. I think that was right. No, it wasn't. B was right. The only thing that determines end diastolic volume is venous return. Just because I put all this crap down here doesn't mean I use it. Sometimes I do, sometimes I don't. Yesterday in Science Phys, I threw up an option that I never use, which is none of the above. I hate none of the above. All right, blood. You recall that most of the body's water is in the cell. Then what's outside of the cell, only a small portion is actually blood plasma, but this is an important portion in terms of what it does. Graphic showing that. Okay. The exchange of fluid between the capillaries and the tissues. Is affected by two factors. We'll keep this here. But you still got to think about, now I'm talking about tissue volume, we're talking about blood volume here. So this is still relevant. All right, two factors. Hydrostatic, think of this as blood pressure, and colloidal, osmotic, or osmotic colloidal. This is the amount of protein in the blood. So the higher the blood pressure, the more fluid leaves the capillary into the tissue. If you put more pressure into the tissue, then you push water back into the capillary. Pretty simple. Another reason why high blood pressure is bad, it's pushing fluid out of the blood into the tissue. And if we're talking about the lungs, that's a problem. I mean, it's one thing to have swollen feet. It's a whole nother thing to have swollen lungs. So the higher the blood pressure, remember, there's one of those people that has the congestive heart failure in that lab report has elevated blood pressure, which explains then part of the problem with fluid being pushed into, I think it was her, lungs. So when you prop your feet up, you've decreased the pressure in the capillary relative to the tissue pressure. So fluid moves from the tissue back into the capillary. That's why you raise edematous limbs. If you put on compression stockings or ACE wraps or those mechanical doohickeys that squeeze, you've increased pressure in the tissue as compared with the capillaries, so it pushes water back into the capillaries. If you're standing on your feet all day, the pressure in the capillary is greater than the pressure in the tissue. So fluid moves from the capillary to the tissue, which is why my mother wore support hose as a nurse. And I started to in ICU as well, when I started doing those 12-hour shifts. All right, now the other one to talk about is the colloidal osmotic. Protein pulls water or hangs on to water. Hangs on to water. Protein is not supposed to be in the interstitial space. Let me say it again, no protein in the interstitial space in normal, healthy people. If protein leaks into the interstitial space, it pulls water out of capillaries. So this explains the swelling of preeclampsia, and it explains the swelling of hypothyroidism, because they have protein that leaks into the tissues and it pulls water. And that particular kind of edema is called mixed edema. When they have untreated hypothyroidism, they get swelling. All right, now if there's not enough protein in the blood, it also will not hang on to water. So when the liver fails, protein is not being produced, albumins. The plasma proteins come from the liver. So in liver failure, there's no more albumin. No more albumin means protein levels in the blood drop, fluid leaves the blood. And so the person who is end-stage liver cirrhosis, end-stage failure, is also very swollen. And they get a lot of swelling here in the abdominal cavity. It's called ascites. It's a special kind of edema that fills the abdominal cavity because of a failing liver. Okay, those are the two forces that are working on each other. That's one of the things when you get the down and out into your hospital, not only are you giving them albumin, a little jar of albumin dripping in because their albumin levels will be low because of liver failure, but also you'll be giving them something called a banana bag, which is an IV bag with vitamins in it. So it's yellow in color. So the capillary has got some little, the regular capillaries in the body. We'll talk more about capillaries when we get to the kidneys. Got some little spaces, so that's why water's leaking. Remember, that's exchange. Capillaries are the exchange vessels. It was, again, Ernst Starling who determined which way is fluid going to go. Is it going to go into tissues or is it going to go into capillaries? And then these two forces are considered as they are a push-pull, and then you see which one wins. So from your book showing the arterial end is at higher pressure, therefore it pushes water out into the interstitial space. The venous side of the capillary is at lower pressure, so most of the water comes back, but not all of it.
At the arterial end of the capillary, the net filtration pressure is equal to the net hydrostatic pressure minus the net osmotic pressure. The net filtration pressure is 13 millimeters of mercury. This causes fluid to move from the capillary into the interstitial fluid. At the venous end of the capillary, the net filtration pressure is equal to the net hydrostatic pressure minus the net osmotic pressure. The net filtration pressure is minus 7 millimeters of mercury. This causes fluid to move from the interstitial fluid into the capillary. Approximately 9/10 of the fluid that leaves the capillary at its arterial end re-enters the capillary at the venous end. About 1/10 of the fluid passes into the lymphatic capillaries and returns to the bloodstream via the lymphatic system.
And so there's the lymphatic system. It has these low pressure lymphatic fingers